This lecture is going to cover musculoskeletal abnormalities and OB anomalies. We're going to review what the normal ultrasound appearances of extremities, talk about the different terminologies that you may see, and then we'll talk about protocol adaptation specific to skeletal abnormalities that may be found, and recognizing different genetic influences that are important to be aware of. And then we'll talk about some specific syndromes, their definitions, their specific ultrasound appearance, and then what they are associated with as well. So reviewing normal, here is a measurement of the humerus. So remembering when we're looking at the humeri, we want to make sure that we have that bone straight across the image, perpendicular to the sound beam. So even more a little bit flat than both of these images would be best for measuring, and we measure at the center of the bone from the diaphysis to the diaphysis, and we want to make sure that the image is zoomed up on that bone and not having too much extra in the image. Confirming that the humeri length is in accordance with the expected growth of the fetus is important. You may see some sites doing the humerus measurement routinely, but it is not necessarily required for routine growth or anatomy scans, but those level 2s or higher level detailed anatomy exams do the humerus measurement routinely. Then when we are looking at the other bones of the arm, the radius and the ulna, usually we just demonstrate them next to each other, but they are also something you can measure. So you would use the same technique, zooming up, making sure they are perpendicular to the sound beam, going straight across the screen, and then identifying the radius and the ulna and measuring them respectively. The radius is going to be closest to your thumb, pretty rad, so thumbs up, and then the ulna will be closest to the pinky. And the radius does appear to be a little bit thicker in appearance than the ulna. And then we also want to identify our hands. We don't really need to put numbers on them, so that's what it means saying only if they are normal or abnormal, would you put numbers on there. But we want to identify that we see a normal amount of fingers, 5 fingers, 1, 2, 3, 4, 5, if necessary number. If you see an extra digit or less than normal, then you would want a number. Just know that digits that are extra sometimes are not the same size as a standard digit, so it could be smaller and kind of in an abnormal place. So this is that open hand view. This is great if you can get it. It's great to see an open hand, not always the case. A lot of times you're seeing that hand more cutting the beam like this. So you see those fingers in cross section. Femur is going to be the same style of imaging as that humerus, zooming really close up. This is a great picture. You can see that femur going straight across, measuring at the center of the bone. And then comparing to their nomograms, you only need to measure one femur. If you do have measurements of bones that are abnormal, though, you have bought your ticket to measuring every single long bone. So we'll talk about that a little bit later, but having good technique on measuring is important for all patients. And then the tibia and fibula, we identify those, and those can also be measured. So the tibia is going to be more medial and the fibula is going to be more lateral. The tibia is typically a little bit thicker, and then the fibula is a little bit longer. So if you are having trouble, follow down to the foot or follow up to determine what's medial versus lateral. And then again, comparing to normograms. We also want to look at the comparison of those lower leg bones to the foot. Is the foot have a normal position, or is it turned in like club foot? So this is one way to demonstrate a normal foot position, to have that look. or you can do looking at the bottom of the foot or kind of that footprint appearance. And labeling right and left is always best, but if you have to do foot 1, foot 2, you can do that as well, and then counting the toes. Again, you do not need to put numbers on there for counting of the toes, just making sure you're counting every time. Here's an example where they did count the toes and labeled left foot. Again, not necessarily necessary when normal. We also want to look at the contour of the foot. Is there anything abnormal about the... I wanted to go back, but I can't. Is it rounded on the bottom, or is it more flat? Or do you notice that the toes are spaced out anywhere? Or do they look normal and condensed like they should be? So that's a review of normal. Just a little bit of some overview of skeletal dysplasias. Genetics can be a factor, but some are unknown if they have a genetic factor or don't. And there are many, many skeletal dysplasias out there. We are not going through all of them today or during this program. And you don't need to know all of them, but just be aware that if you do find something abnormal, that it is likely one of the many things that can happen. But then there are the more common of them that can happen, and those are the ones that are important for you to be aware of. A lot of them are lethal, so that is unfortunate, but something also to be aware of. The ones that are commonly tested on for the board exam are thanatophoric dysplasia and achondroplasia, but also knowing that thanatophoric dysplasia and achondrogenesis, which is different than achondroplasia, are going to be the most common dysplasias that are found and account for the most or the majority of lethal cases that are noted according to our textbook as of 2017. So skeletal dysplasias are only about 2.4 in 10,000 births. So they're not really that common, especially these really rare ones. So, but they do happen. I have definitely seen some in my time that were just not great outcomes. So one thing to be aware of for just the skeletal dysplasia section is some terminology. So these are really easy board questions for you to get asked, just knowing the definition of these terms. So knowing what the where the location is of the abnormality and what the abnormality is. So rhizomelia is a short proximal portion of a bone limb. So that would be the proximal part is going to be closest to your body, so that would be your humerus, your femur, or it could even be a hip or shoulder bone. Then mesomelia is going to be that midpoint, so the forearm or the lower leg. Those bones are short. And then micromelia would be the entire limb. So sometimes it's just an upper limb. The upper limbs are just the lower limbs, but it would still be considered micromelia. Same with meso or rhizomelia. And then acromelia is going to be short or absence of shortness of the hand or feet bones. Syndactyly is fusion of bones or soft tissue. This is also known as webbing of the hands or feet. You maybe have heard of people who are good swimmers sometimes have webbed hands or feet. I don't know if those are true things or not, but I've heard that before. And then polydactyly maybe is one of the terms you have heard before. This is an excessive or additional digit that can be in the hands, the fingers, or the toes. Fun fact, cats have polydactyly a lot. So here is just a little depiction showing normal versus rhizomelia, where we have that shortening of that proximal bone, but normal midpoint bones. Mesomelia, shortening of that midpoint bones, and then micromelia with shortening of all of the arm bones or limb bones. And then all of these three would be considered limb dysplasia. Additional terminology to be aware of. This term can be spelt a couple different ways, so just kind of be aware that is achuria, that's absence of the hands. Apodia would be absence of the foot or feet. And then we also have a couple others. Clendactyly, which is fingers that deviate from the normal position, so aren't in our standard position. They can be turned in or out. And then we can have ectrodactyly, whereas there's clefting or splitting. So usually you have kind of some combination of syndactyly and ectrodactyly, where there might be some fusion and splitting into the hand or the foot. And you can look up images of all of these things if that helps you remember these terms as well. And then platospondylia is flattening of the vertebrae, also known as platospondyly. Again, one thing that has two different terms for the same thing. So that is, of course, a skeletal portion of the baby, so we also want to evaluate the vertebrae. So this isn't really a limb development thing where it's genetic or something that was wrong with the baby, but did happen and caused an abnormality. So we've talked about amniotic band syndrome, where we have those amnions or amniotic sheets that can wrap around any portion of the baby, causing abnormal development. So we might have amputations that may occur, or we might have smaller digits or limbs that happen because of that. It can restrict any part of the baby though, so once you see this, you want to evaluate the whole baby to make sure anything else may not have been impacted. And here's a link to look up a little bit more about amniotic band syndrome as well. So polydactyly, here's an example of an additional 6 digit. You can tell that this digit is kind of sticking out to the side slightly and is a little bit smaller in size or length than these other digits. And then here's an extra little toe that you can see. So we have 1, 2, 3, 4, 5, and then 6. So notice that it's not necessarily exactly in line with the other toes. It's kind of coming out. So that's why you always want to scan through an entire hand or foot to make sure you don't miss any of those things. And then here's an example of a 20-week fetus with achyropodia. So they actually had it bilaterally of the hands and feet. Absence of both of those were developed. You can see here are the legs, the lower limbs, and then absence of the feet. And here is the absence of the hand. And this is a 3D view of those things as well. It wasn't really known what caused this for this child. Syndactyly, again, is the fusion of digits. So you can see that these two fingers are fused here. It's hard to tell on ultrasound if the skin is completely covering or how that's going to look without the 3D render, but you can tell that they are stuck together basically. And then you can have syndactyly with polydactyly as well. You can have a combination of some of those terms. So we have a fusion of digits as well as additional digits. And then here we can see that as well at the feet. These are both examples of feet. You can have partial absence of a hand or foot. So this is partial apodia, where we have a very small foot. We do have some toes, but we're missing some of those foot bones. Again, something you would want to demonstrate and may be important for diagnosis or after birth care. And then clendactyly, that's the deviation from normal. You can see that this finger, I believe is the pinky, is turned in. This can be a characteristic of Down syndrome, so that's something you want to demonstrate as well. And then here's ectrodactyly, so that's that kind of clefting of the hands. This actually, baby only had 2 digits and then absence of the additional digits because of that cleft, and this is what it would look like on ultrasound. As far as I know, I believe this is actually a dominant trait, so if a parent has this, it is pretty high likelihood that a child will develop this as well. And then platyspondyles, this is the most common spinal abnormality that is seen when there is a skeletal dysplasia, and we see flattening of the vertebrae. So instead of that nice triangular shape, it's more flattened and wide in appearance. So when it comes to our protocol, normally we do our measurements of our long bone, of our femur, sometimes our humerus, for growth. If it's an anatomy scan, we're going to identify and show the bones of the lower arms and lower legs, and then the hands and feet. But if you notice things aren't looking correct, you're going to start doing some additional things. So you might be doing additional measurements of both arms, both humerus, both femurs, not just one, and then both the radius ulna and tibia and fibula, the length of all of those things. That's going to take extra time. So if you notice that you're going to do that, you need to step out of the room and let a coworker know, hey, I have to do all my long bone measurements. It takes a while. Sometimes you need that baby to move to get good images of those other bones. You also want to look at the amniotic fluid. Is there appropriate amount of amniotic fluid around the baby? Does the bone look in a normal brightness and calcified mineralization that you would expect to see? Is it not quite as mineralized? Is there any shadowing from the bone? If not, maybe it's not quite as thick and developed as it should be. Are the bones shaped or fractured differently? So normally we see those long bones nice and straight. They can be bent, they can be curved, or they can be actually fractured. So any of those things you would definitely want to show and know which side it is. Is the skull normal in shape? Going back to that first week of frontal bossing, craniosynostosis, and then Klebat-Shadel, which is actually that severe form of the cloverleaf skull. Do we see normal facial features? Is the thorax normal in size? Are those lungs developing normal, or are the ribs really small? You can actually measure the ribs if needed as well. Here's an example of determining if that thorax is normal in size. So you'd want to be at the level of the 4-chamber heart, magnify up to that chest, do a circumference around the heart. It should be about 1/3 of the circumference of the chest, and then the position of that heart should also be pointing leftward. And you can also use additional worksheets or documentation to help you remember what you need to do. So this is doing all long bone measurements, making sure we know what's right and left. This is another reason why I just want you to always know what is the right side of the baby and what is the left side of the baby, because if you come across something abnormal, you already know what you're working with instead of backtracking and trying to figure out what's right and left of that baby. So you would do your long bone measurements, the length of each of those bones. You might need to compare what it should be for normal, comment if it's normally mineralized or not, if it's shadowing or not, is it curved or fractured, and then is anything absent, hypoplastic, or malformed, making comments on that. And then you can also add in those chest circumference and heart circumference measurements and comparing them to normal. Is the shape of the thorax normal? Is it more bell-shaped? Are any bones missing? Are there any extra digits? Is there any fusion of anything or any deformities of the hands or feet? You can even measure the clavicles. I've never had to do that, but I can see it being done if needed. You can measure the foot as well. There is a foot to femur ratio, like I've told you in other course classes, that there's a normal reference range for like pretty much anything you can measure in OB. So there's lots of measurements you can do. If something looks abnormal, there's probably a reference range for it. There's also other things. Are we seeing normal motion, normal fluid? Is the face looking normal? Is the skull normal? Do we see any abnormal shapes there? And then you can just make any comments in looking at the eyes. So this is a worksheet that was developed at the University of Washington and can be helpful for reference on those skeletal dysplasia images we need to take. Clinical management is important to know. So you want to do a family history if it has not been done already. Some people are going to know that they have skeletal dysplasias that run in the family. Some things are going to be dominant and some are going to be recessive. So if it's a recessive trait, that would mean mom and dad are carriers, but they don't express that gene. And if it's dominant, one of those parents has that genetic trait and it's displayed. If not known for any of those things, there may be some genetic testing that needs to be done. So if we do find a skeletal abnormality, we do need to do some serial growth and some monitoring, extra monitoring of these babies. So anytime a growth measurement of any, a measurement on a baby of any time is below 2 standard deviations of the expected, then they're going to be considered small. So that would be the humerus, the femur, the radius, the ulna, the abdomen, the head, all of those things. If one of those things is small, then we are going to monitor them for growth. And then anything less than the 5th percentile overall for growth compared to that gestational age is also concerning. They do use the 10th percentile for growth restriction, but when we're talking about skeletal dysplasias, we're getting even lower on that threshold, so below the 5th percentile. And then you can look at the thoracic circumference. That's going to tell us some predictability about that lung function after birth. Is there enough space for those lungs to develop? And then again, some chromosome testing of the fetus may need to be done to give some insight into what's going on for that patient and that baby. And then depending on what the diagnosis is and what the growth is and how the pregnancy progresses, early delivery may be necessary to help with lung support, or planned C-section may be required to help with just that baby really surviving the birth, because birth can be really hard on a fetus. Okay, so we're going to talk about this actual skeletal dysplasia. So these ones first are actually abnormalities of cartilage and our bone growth development. So then the nataphoric dysplasia, again that's the nataphoric dysplasia, is categorized into a couple different types, but things that we can see are abnormal long bones. They can be bowed, they can be short, they can be just part of the bones are short or all of the bones. You'll see an abnormal shape in the thorax where it looks really small. You can have a normal abdomen, a large head, and then we can see polyspondyly or really flattened vertebrae as well. Other things you might notice are horseshoe kidney, ASDs or atrioseptal defects, imperforate anus, and then in some cases a clover leaf or clavachadel skull. So there are 2 types of thanatophoric dysplasia. The most common one is type 1. That's where we see curved femurs or telephone receiver femurs or like banana-shaped femurs. And these ones don't have an abnormally clover leaf skull shaped. Then there is type 2, which has straight bones, no curving of the long bones, but does have cloverleaf skull. Either way, either type is lethal, unfortunately, and this is the most common lethal skeletal dysplasia. So this is a big board question I've seen. What is the most common lethal skeletal dysplasia? The nataphoric dysplasia. So you might see kind of a variation of things, but looking at those limbs, the skull, and then is that chest normal in size or do we see poly? So here's an example of a skeletal or thanatophoric dysplasia at 18 weeks. And on the first set of images here, we can see micromelia. We have a really small long bones. They're almost like just little ditzels there. And then we can also see that the chest is really small. So this is an 18-week fetus, and all of these structures are measuring at 14 weeks. And you can tell that the spine is flattened here. And then on this other image, we can see narrowing of that chest. So that is a poor outcome for lung development. Some people call this champagne cork chest. And here is a video clip. You can see some severe micromelia demonstrated here. Let that run again. Long bones are very short. Sometimes these bones are so hard to measure because they're so short. So that's the gnatophoric dysplasia. Achondrogenesis is a different skeletal dysplasia where we have failure of ossification. There are different types. You don't really need to know the different types. You just need to understand the term here. But these are kind of the sub-findings of the different types. But on ultrasound, you'll see shortened limbs, lack of ossification of the vertebrae, as well as the cranium. We can see poly, hypoplastic thorax, and then cystic hygroma can actually be seen in this as well. The other thing is we may see a hitchhiker's thumb, which is a thumb that's really extended really, really far back. I can't do it, but maybe you've heard of people that can do that. So that is kind of just specific to this achondrogenesis. Here are some examples of achondrogenesis where we don't see ossification of the skull. So when you're scanning and looking at the long bones, or any of the bones I should say, you just scan right through them. It's like there's no bone there. It's here to really hard to kind of even identify the spine or the cranium in these babies because of that lack of ossification. Here's another example of a 24-week fetus that had decreased ossification. So looking at the head, we can see all those head structures really well. And remember, typically that anterior portion of the brain is a little bit shadowed from the cranium. So if we can see those structures really well, it's a little bit concerning. And then looking further into the other portions of the baby, we notice severe micromelia of the femur and humerus that were more consistent with a 13-week gestation versus a 24-week gestation, which this baby was. Right, moving on to achondroplasia. So this is one that is not lethal. So this is the most common non-lethal skeletal dysplasia, and we see abnormal shortening of the long bones due to decreased endochondral bone formation. And this is one that can be heterozygous or homozygous. Heterozygous is where we have an inheritance from one parent that has that dominant gene. They can have complications with this. And then homozygous would be where both parents have had the dominant gene and passed it on, but that actually does have a lethal diagnosis. So we don't see that as often. So here's examples of what we might see on ultrasound. You may see rhizomelia, macrocephaly, so the head is a little bit bigger than normal, a trident hand where there's a wide space between the third and fourth finger. You can actually see that here. You may see a depressed nasal bridge, that frontal bossing, seen here, and then is usually a little bit more apparent in the mid to late second trimester. So may be missed on that 20-week scan, especially if it's at like 18, 19, early 20 week. So something to be aware of. The femurs would be short though, as well as the humerus. Another one is osteogenesis imperfecta. This is a fun one, I think, to say. This is where we have a disorder of production of secretion or function of collagen, which results in hypomineralization. There are different types. You don't need to know the different types, but do know that some of them are lethal. I have had adult patients that had I can't remember if it was type 1 or type 4. But I did have adult patients that had this, and they had just had many, many broken bones in their life. So they did not have the lethal one, of course, but it is something to be aware of. So if you see osteogenesis imperfecta, those people are kind of fragile, also known as like the fragile bone disease. So what we might see on ultrasound is the bones might look undermineralized. They may have a more normal appearance depending on which type they get, but you might notice that the bones have fractures. It could be any bones. It could be the ribs. It could be the arms. It could be the legs. It could be the fingers. It could be the head. So if you notice just there's something doesn't look right, look closer. Why is that? Is it the size? Is it the shape? Is it there's something broken? So when you're measuring, make sure you're still measuring the whole bone, not just a portion of that bone. So here's an example. We see hypermineralization of the skull as well as the chest. Camptomelic dysplasia, this is where we may see bending or bowing of the long bones, and this can be associated with a variety of things. So something to be aware of. And when we find it on ultrasound, we typically see the bowing of the femurs, or those long bones. The shape of the chest may be bell-shaped. We may note polyhydramnios as well as hypoplastic scapula. So here's an example of a fetus that's 20 weeks old with bowing bilaterally. You can see the bowing of the femur as well as the fibula and tibula. The lengths were normal though, but we did see some abnormalities of hypoplastic measurements in the fibula, and tibula. And then the upper extremities were normal. So remember, this is when we see the bowing in the lower limbs. This patient also had hydronephrosis, that hypoplastic scapula, and genital dysgenesis. So they were diagnosed with camptomelic dysplasia. And then just another term to know, dysostosis is an abnormal formation of the bones. This can be seen in the cases of a cloverleaf skull. So just kind of a term to be aware of. Right, postural abnormalities. So this would be where the arms, body, or limbs aren't in the typical position we would expect. Clubbed hands, so you've heard of clubbed feet, but the hands can club as well and be turned into odd positions. So that's usually an abnormal position or rotation of the hand. Usually it's going to be on the radial side, so where that radius is, the hand moves in and is almost falling into the arm. Then we can have it on the ulnar side as well. That's less common. If you see this, you want to look for other things like scoliosis, some specific syndromes as well, and checking out that heart. So kind of going along with that, there's something called radial ray anomalies. So I'm just going to emphasize that this is not something I have seen commonly. However, for some time, I haven't heard recently, but for a period of time, this was really commonly tested on the board exam. I don't know why, but almost every student I had at least 5 questions on this on their board exam. So just be aware of it. Not super common, but I do want you to be aware of it just in case it comes up. So this is where we can have a spectrum of upper limb abnormalities of the radius. The radius can be short or hypoplastic or completely absent. Either way, that's where that clubbing can happen because the hand basically falls into that radial side of the arm because it doesn't have that radial bone stopping it and keeping it in the correct position. There are different types. Don't think you really need to know the different types so much. I do have them listed there just in case, but knowing those associated things is important and just what a radial ray anomaly is. Here's some x-rays demonstrating it a little better than the ultrasound picture. So here we see absence of that radius. We also see abnormal length of that ulna, and then number of digits, same here. Here that ulnar bone is bowed as well, and then the absence of the radius. Here's an example showing a normal left arm and radius and ulna, and then an abnormal right arm with a curved ulna, absent radius, and then abnormal digits and hand bones as well. Talipes equinovarus is another term or name for clubfoot, which you've heard before. So that's where that foot is turned in abnormally inverted and flexed as well. This can be caused by a lot of different things like amniotic band syndrome or oligo if there's just not enough space for that baby to stretch out and form normally. Same with uterine tumors can cause that. But it is associated with chromosomal abnormalities, spina bifida, and sometimes is isolated. I do know people that have had kids with just club feet and it's just isolated. But if you see it, you want to make sure you're looking through the whole baby and not missing any abnormalities that could be reflective of a chromosomal problem. But when you're looking on ultrasound, you're not able to get that nice flat foot look, either from the side or that footprint. If you're trying to get that footprint, you'll always get the bottom of the leg or the whole leg in there. You should always get the foot by itself. So if you're having trouble with that, make sure you're scanning through the whole leg and able to demonstrate, and then also looking at the other foot. Here's a video clip showing clubbing of that foot there. You can see they're having trouble getting that flat foot appearance, and it is turned in. I'll let that run one more time. It looks like it's on both sides. Something else to be aware of is called arthrogryposis multiplexa congenita. This is where we have contractions of bone joints. Usually this is symmetric and typically includes all the limbs. So what that is the baby is really contracted like this, or sometimes almost the opposite and stretched way out. It is associated with Coxsackie-A virus. Can also be associated with oligo, which makes sense if there's not enough fluid for the baby to move around and get that tone. Lots are enlarged fibroids, and then also neurologic or muscular abnormalities. So on ultrasound, you may notice lack of fetal movement due to those contractions where the baby is really contracted like this, and this can be seen really early in pregnancy in that first trimester. Or we just really see severe flexion or extension. Depending on how poor movement there is, it can have a pretty severe prognosis or less severe. So here's some examples of what that might look like. We have contractures of the elbow in this first image here, and the wrist. And then in this example here, we can see contractures at the knee and the ankle, as well as a clubbed foot. And then on 3D images, you might be able to demonstrate that in a way that's a little bit easier to appreciate, as well as showing the bones that are involved here. This is a skeletal version. Thanks for making it all the way to the end. I have this lovely thing from Summer Gardens that you all might like or dislike, and I may ask a question about in class. Here's my resources.